Thank you. Good afternoon, everyone. My name is Yvonne Millerick, and I am a heart failure palliative care nurse consultant. I work in NHS Greater Glasgow and Clyde in Bonnie, Scotland. I'm also a wife to Gary and mum to James and John. And together as a family, we have a family pet called Bobo. And these are the things that matter to me while I'm well, but also during periods of feeling less well and less able to do things. And that this will become more apparent as the presentation progresses. As we go through the presentation, I would like you all to take part in a small activity, which is called the Head, Heart, Carrier Bag and Dustbin exercise, which goes something like this. For the head, I would like you all to think about something that you have learned from participating in this session. For the heart, I would like you all to think about something you have felt from being part of the session. And for the carrier bag, I would like you to think about something you will take away from being involved in this session. And finally, for the dustbin, I would like you to think about anything that you would want to forget or that was not so good about being involved in this session. And I'm hoping that that won't be my full presentation. So I've been asked to share with you all my experience of working in partnership with patients and families who have been diagnosed with advanced heart failure. So what I would want you to take away from today's session is to know that heart failure is common, it's costly, and it's also disabling. And that early diagnosis, proactive management, and timely reviews definitely saves lives and improves quality of life. Cohesive working between care providers and people living with advanced heart failure enables the realistic facilitation of what matters, why it matters, and when it matters. And these are the principles of optimal care and support delivery. What is heart failure? So a healthy heart is able to pump blood around the body to provide the muscles and the organs with enough oxygen and nutrients to meet the body's demand. However, the heart can begin to fail if the chambers become damaged, enlarged, or stiff, or it can fail due to valvular problems. And this affects how well the heart pumps, how well it relaxes, or how well the blood flows through the heart. So there are different types of heart failure. Heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. And the ejection fraction is the amount of blood that's pumped out of the ventricle divided by the total amount of blood in the ventricle. And a normal ejection fraction is usually between 53 and 75%. Mild ejection fraction is 40 to 53%. Moderate is 30 to 40, and severe is usually less than 30. So what is the burden of heart failure? Well, globally, it affects more than 21 million people. It's affecting almost 1 million across the UK, and it accounts for 5% of all emergency admissions to hospital. Sadly, patients who are admitted to hospital, 9% will sadly die, and 27% die within 1 year. The total cost of heart failure on the NHS is also significant and represents 2% of the total NHS costs collectively. So the possible causes of heart failure are, can happen for lots of different reasons. There is no agreed or satisfactory classification for the causes. but there is much overlap between potential categories. So the main reasons why heart failure develops is coronary artery disease, heart valve problems, high blood pressure, pulmonary hypertension, congenital heart disease, and inflammation of the heart muscle. Cardiomyopathy can cause heart failure, although the likelihood of this happening is significantly reduced due to the treatments that you're already receiving. So the classification of heart failure is about assessing symptom severity. And we use two different classifications. The one that is broadly used across the UK is the New York Heart Association Functional Classification. And this is based on symptoms or physical activity. For advanced heart failure, we would be focusing on people who experience symptoms associated with class 3 or class 4 symptoms. And we define this by class 3 symptoms as simply people who have marked limitation of physical activity, but remain comfortable at rest. However, less than ordinary activity results in heart failure symptoms. Classification 4 symptoms is when heart failure symptoms are present at rest. And if any physical activity is undertaken, then there is increased discomfort. The American College of Cardiology stages heart failure based on the structure and the damage to the heart. And again, it's staged from stage A, B, C, and D. And for advanced heart failure, we would be looking for between stage C and stage D classifications, which are defined by symptomatic heart failure associated with underlying structural heart disease and who have marked symptoms at rest despite being on maximum tolerated medical therapy. The symptoms of heart failure are usually what brings people to clinicians' attention. And many of the heart failure symptoms are non-specific and do not therefore help discriminate between the types of heart failure and other problems. Symptoms that are more specific to advanced heart failure include orthopnea, which is requiring to sit more upright at night while sleeping, and paroxysmal nocturnal dyspnea, where people become breathless at night and perhaps waking up short of breath. These symptoms are less common in more stable heart failure, but are certainly prominent in the more advanced stages. But people can experience varying degrees of peripheral edema, which can affect their feet, ankles, legs, thighs, and abdomen. They can also experience different types of breathlessness, which we normally divide into breathlessness at rest, or exertional breathlessness, or paroxysmal nocturnal breathlessness. People often describe overwhelming symptoms associated with fatigue, and I often ask them to describe their sleep pattern, because fatigue is a very different symptom from tiredness. Tiredness can be minimised normally with quality sleep, even if that quality sleep is only 2 to 3 hours each night. But with fatigue, people will feel fatigued at night, and after a good night's sleep, it is still often the one symptom that they complain about when they're waking up in the morning. Cough can also be troublesome, and again, it can alert people to a sign that things are perhaps changing for them, particularly if they're troubled with the cough at night. Additional symptoms associated with advancing heart failure are related to patients experiencing poor psychological well-being, generally associated with anxiety and depression, although it's not in stable heart failure, this can still be a significant symptom. Generalised pain associated with breathlessness and using accessory muscles, and resistant pain or resistant edema can often cause pain associated with aching legs, tight skin, pulled over, badly swollen legs and thighs and feet. And generalised pain associated with reduced mobility, poor sleep quality. These are things that we are often looking out for. Patients can also experience a reduced appetite and have symptoms associated with nausea. And this can sometimes occur because they are having what we call edema in their gut, which gives them a feeling of fullness constantly before they even have anything to eat. And that can be commonly associated with advancing heart failure. So the NICE, ESC and sign guidance provide evidence-based information to support diagnosis of heart failure. And it includes blood tests such as the brain natriuretic peptide, which is a hormone produced by the heart and which increases in relation to heart failure. The ECG or electrocardiogram looks at the electrical activity of the heart, and this is very seldom normal in the presence of heart failure. An echocardiogram is an ultrasound scan of the heart which examines the heart structure and identifies the type of heart failure, whether it's preserved or reduced ejection fraction heart failure. The MRI also looks at the heart structure and looks at the blood flow through the heart. So treatment of heart failure following informed diagnosis is again evidence-based, and it is available in the NICE, ESC and SIGN guidance. And it does include different classes of medication. Diuretics are usually given to help reduce the water retention, which causes swelling in the ankles and around the lungs, and by encouraging the kidneys to produce more urine. This may or may not be needed once other therapies are introduced, but it is important that patients acknowledge the relationship between their diuretics and the appliance, and when appliance is not so good, then the development of fluid may return. ACE inhibitors relax and open up the blood vessels, which makes pumping blood easier around the blood vessels and takes the strain off the heart. And they can also control the blood pressure and prevent the heart failure symptoms from getting worse. Beta blockers are used in combination with the ACE inhibitors and slow down the heart rate and control any arrhythmias. The angiotensin II receptor blockers are similar to ACE inhibitors by relaxing blood vessels and lowering the blood pressure, but they are sometimes used if ACE inhibitors are truly intolerant of for the patient, and this usually means that they have an intolerable cough due to the adverse effect of the bradykinin. Aldosterone antagonists are a type of diuretic which are used in combination with ACE inhibitors and beta blockers, and they stabilise fluid over a longer period of time. Ivabradine is another drug which helps to slow down the heart, and it may be used for people who are not able to tolerate beta blockers and whose heart rate is greater than 75 beats per minute. Digoxin is an old-fashioned drug, and it is making a comeback. And we certainly use this in advanced heart failure to slow down the heart rate while making the heart contract much stronger. And this again may be used when ACE inhibitors and ARBs and beta blockers and diuretics are not able to work as effectively as before. So they're used in combination. The new drug to the gang is sacubitril and valsartan. I prefer to call it Entresto because it's much easier. Contains the ARB valsartan and an antihypertensive drug called sacubitril. It is new and the evidence is quite overwhelming. It's only used when within the NICE guidelines, and ACE inhibitors must be stopped prior to Entresto being commenced. Additional therapies that may be considered in the management of advancing heart failure symptoms or to prevent advanced symptoms is devices. And these devices are used when medication doesn't control all of the symptoms or to prevent symptoms from getting any worse. And devices help to monitor and control the heart rhythm or help electrical synchronization through the heart. And I don't want to focus on that anymore because I realise that you've had a talk on that earlier today. So unfortunately, heart failure very seldom comes in isolation and is usually associated with more than 3 comorbidities. And they can be anything from renal dysfunction, chronic obstructive pulmonary disease, diabetes, atrial fibrillation, depression, anemia, hypertension. So what is advanced heart failure? So there is no widely accepted definition. Severe heart failure occurs despite optimal tolerated conventional evidence-based treatment and usually results in NYHA classification 3 or 4 symptoms. People require frequent hospital admissions with decompensated heart failure and require frequent diuretic adjustment in response to resistant symptoms. Heart failure does have an unpredictable disease trajectory, which is often characterised by patients experiencing many years of cardiac ill health, which does inevitably lead to uncertainty regarding a definitive diagnosis of advanced heart failure. And what is important about this is that although many people would prefer to be cared for at home, in the absence of being able to identify advanced heart failure and be able to coordinate cardiac palliative care, the reality is that many of them will continue to experience hospital admissions associated with subsequent deterioration and further change. And that change may represent further deterioration. And for some, it may represent death. The uncertainty associated with heart failure also leaves professionals feeling a lack of confidence about when is the right time to introduce cardiac palliative care. And this ultimately discourages early identification, appropriate decision-making, and effective management. In addition, patient, family, and professional expectations can be unrealistic. The uncertainty and unrealistic expectations remain key drivers for poor understanding, repeated hospitalisation, accumulating healthcare costs, and a very real risk of patients experiencing care and support that does not align with their care preferences. Changing perceptions is absolutely essential, and we do this by acknowledging that the one certainty throughout the advanced heart failure trajectory is irreversible decline, where the person experiencing the ongoing symptoms and frequent heart failure decompensations never gets back to the health and well-being status that they had previously experienced. And this graphic here highlights that subtle decline taking place. And what this feels like for people who are living with the impact of advancing heart failure is that there are no, in the absence of definitive decisions regarding ceiling of treatments, advanced care planning, support for patients and their carers, there is no realistic choices for cardiac palliative care. And this results in patients and families experiencing a loss of autonomy, recurrent hospital admissions, increasing symptom burden, poor quality of life and quality of care, and unrealistic expectations. But what are we doing about this? And the Caring Together programme was an innovative partnership between Marie Curie, the British Heart Failure Foundation, and NHS Greater Glasgow and Clyde. And the partnership was created to improve the quality of cardiac palliative and end-of-life care for people in the advanced stages of heart failure. The partnership was developed and piloted integrated core components to help people living with and dying from advancing heart failure in order to help them experience better quality of care, improve symptoms, individualised care planning, and alignment of realistic care preferences. So the programme objectives set out to meet the needs of patients, carers and professionals, complement the optimal management of heart failure and coexisting conditions. So it wasn't that cardiac intervention stopped and cardiac palliative care commenced. They would run parallel to each other. We wanted to promote equity of access to partner services and acknowledge, enable and facilitate increased choice of care preferences. And throughout the programme, we wanted to improve awareness and coordination of care amongst all stakeholders. So throughout the Caring Together partnership and engagement with key stakeholders, an action research methodology was used to develop and refine key resources to support professionals in clinical practice. The clinical resources highlighted here include a comprehensive holistic assessment tool that enabled the discussions around medical anticipatory care planning, understanding do not attempt cardiopulmonary resuscitation, and deactivation of cardiac devices in a timely and appropriate manner. Additional activities included a training needs analysis of multidisciplinary professionals, patient and carers' experiences of living with advancing heart failure was appraised, and the outcomes of that are very much integrated into the core components that have been developed. So the core components that have been developed include early identification of people who are living with advancing heart failure, despite being on optimal evidence-based treatments. The second one is a comprehensive assessment to determine the cardiological, comorbidity, and holistic care outcomes. Meaningful conversations enable documentation, communication, and facilitation of realistic goals and preferences of care across all care boundaries, and cohesive working to ensure that optimal and proactive care is provided in a timely and realistic manner, regardless of the care environment. So early identification is based on clinicians identifying patient based on unmet needs and ongoing symptoms, rather than focusing on trying to define a time to death. The idea is that cardiac palliative care does not stop or impair the introduction of cardiac therapies. It does not hasten any deteriorating process. And actually, there is evidence to the contrary that highlights that integrating a cardiac palliative care approach prolongs life and improves the quality of living. Patients and carers who experience the cardiac palliative care model speak very positively of their care experience throughout. So who are the patients that we would be identifying? So people who are experiencing advancing heart failure will be nearing the ceiling of therapy. Now, that doesn't mean to say that they've reached the maximum target doses of the evidence-based treatment. For some reason, that won't be possible for them because they're not able to tolerate it. So ceiling or near a ceiling of therapy means that they have reached optimal tolerated doses of evidence-based treatments. And we would want to consider, is there anything further that could be implemented to improve their cardiac status? These people will have ongoing symptoms with or without hospitalizations, and they will be associated with other complex issues. They may experience a change in another comorbid condition, which potentially can adversely impact on the evidence-based treatments of their heart failure. They may or may not be experiencing increasing frailty and reduced function, and just generally becoming less well and less able to do things. And they may be having frequent adjustment of diuretic therapy to control their symptoms. So next core component is the comprehensive assessment. And this involves comprehensively assessing patient and carers' unmet needs. The Caring Together Holistic Assessment tool was developed to support clinicians to change their focus from disease-specific assessment to a comprehensive approach, which determines appropriate management of the wider unmet needs. The comprehensive assessment involves a cardiological and person-centred appraisal of patient and carers' understanding, their expectations, appropriate goals of care, and treatment plans. And we integrate the use of validated assessment tools to evidence evolving change and to inform appropriate decision-making and further intervention and treatment responses. Core component 3 includes anticipatory care planning and completion of an individualised anticipatory care plan, which is created through meaningful conversations in partnership with the patients, family, and key professionals. Formally communicating and sharing the medical anticipatory care plan with key clinicians across different care boundaries is absolutely essential. And a copy is also given to the patient and his family to keep at home. So to support professionals to engage in meaningful and evolving conversations in preparation of inevitable change, a variety of resources have been developed and include a What Matters to Me communication tool, which encourages discussion regarding what is important, why it is important, and when it is important. Information leaflets have also been developed to support understanding and discussions associated with resuscitation and timely deactivation of cardiac devices. The bespoke medical anticipatory care plan reflects the patient's current cardiological and comorbidity status, realistic treatment and appropriate goals of care, physical, psychological, social, occupational and carer needs, and appropriate management. Bespoke admission avoidance plans are also created to complement the anticipatory care plan, and these provide guidance on specific management of escalating symptoms, which may include breathlessness, angina, anxiety, And these are sometimes the symptoms that cause hospital admissions. Studies have highlighted that patients and families with heart failure not only hope and expect to experience a level of wellness and stability, but they also want to be informed about the treatment options and outcomes, including a strong preference for information to be disclosed about the possibilities of deterioration and inevitable decline. Study participants articulated that their need for truth-telling should be balanced with hope regarding quality of life, symptom management and control of decisions regarding care preferences throughout their illness trajectory and at end of life. Asking what matters to you is a powerful question which captures the very essence of person-centeredness and encourages a personal and compassionate approach to care and support. The question, what matters to you, allows patients to disclose their interests, values and preferences as real people and not just as recipients of care. We know as clinicians that from experience and the evidence that focusing on what really matters to people can lead to big improvements in the quality and effectiveness of the care and the life that they receive and live. We also know that this approach is equally good for professionals as it provides a framework in which they can work towards facilitating support and care that is not only individualised to each patient and family, but more importantly, is informed by them. So what matters to you all here today is reflective of the core values that we hold dearly as individuals. Within each of these will be our own unique values, which are equally important and frame the person that you are, but more importantly, the person that you would want others to know and respect. But how conversation ready are we? We plan and prepare for so much change in our lives, such as marriage, birth, and moving house. And yet we very rarely invest the same amount of time to thinking ahead and making plans for physical, mental, and general well-being changes that will inevitably happen to each and every one of us, and will undoubtedly challenge our core values and impact on the lives of those people who really matter to us. Physical, mental, and general well-being changes will affect us all at some point in the future. Thinking ahead and making plans now will empower us to inform decision-making at a time of real need. These are some examples of the thinking ahead and making plan documents, and your local area will have their own version of these. So what matters to you is about thinking ahead about what your future should look like when you become less well and less able. Who matters to you is about sharing your thoughts, concerns with the people who matter and who can help to create and inform the right plan for you. Why does it matter? Well, it matters because you will be better informed, more prepared, and feel more supported, which leads to being in control about what happens to you. And when does it matter? It matters now. By thinking ahead, you will be able to inform your care wishes for when you become less well, which will improve your long-term quality of life and your peace of mind. So without a doubt, skilled communication underpins all aspects of the caring together approach. And poor communication is commonly cited in publications as a real barrier to delivery of effective care, as highlighted by this paper by Professor Fitzsimmons et al. She found that poor communication was ranked #1 of 3 themes which contributed to suboptimal management and service provision of patients and carers living with the real impact of uncertainty and advancing heart failure disease. We cannot ignore that in order to create thinking ahead plans, such as the medical anticipatory care plan, that meaningful conversations are essential. However, we should also know that talking about the inevitable now does not make it happen anytime sooner. The future for people living with advancing heart failure is uncertain, and this can often make these conversations more difficult. However, the uncertainty and the unpredictability should only reinforce the importance of engaging in meaningful conversations about thinking ahead, making plans now for inevitable change happening. In doing so, we can encourage people to manage realistic expectations and experience true-centred care. This difficult conversation guide has been developed by the British Heart Foundation and the National Council for Palliative Care to support patients, families and professionals to engage in the meaningful conversations. There is also a conversation game commonly known as Hello, and this is an evidence-based game that allows families and professionals to have conversations that they would not normally have, and its focus is very much on living and person-centred values, and it encourages families to explore and acknowledge what is important, why is it important, and when is it important. Cohesive working is the next core component. This is encouraged to ensure timely, responsive and coordinated care, regardless of the care setting. Acknowledging the unique contribution of each professional discipline is absolutely vital and should be encouraged to enhance cross-fertilisation of skills, knowledge and expertise, which has the potential to provide optimal assessment and care provision. But please remember that patients and families are at the very heart of this approach. So what impact is integrating cardiopalliative care components into clinical practice having? Well, we do know that the collaborative approach is providing good heart failure care, generalist palliative care with access to specialist palliative care for advice, support and education. It is promoting a patient-centred, disease-specific, anticipatory care planning approach with engagement of preferences and priorities of care, matching the realistic preferences. From a GP perspective, it's been described as an ideal approach for the modern healthcare system with maximum shared knowledge and awareness and minimal uncertainty through the identification, assessment, planning, communicating, cohesive working and sharing, which ultimately lead to increased quality of life and, sadly for some, a good and dignified death, which leaves a positive legacy. From a patient perspective, it provides a framework which promotes and enables patient autonomy, better understanding, realistic choice of care in anticipation of inevitable change, and encourages clinicians to manage expectations realistically and appropriately. But these service user testimonials are proof that changing mindsets and integrating the cardiopalliative care core components can lead to patients and carers living with and sadly dying from advancing heart failure, experiencing individualised responsive care at the right time, in the right place and at a time of real need. But does this approach align with the National Healthcare Strategy? And the answer is yes. And it does this through cohesive working across care settings, minimising inappropriate hospital utilisation, and integrates the principles of realistic medicine. But I just want to finish off by saying that I hope that all of you leave here today knowing that what matters to you and talking about what matters to you is really, really important. I hope that you feel empowered to have meaningful conversations with your family and healthcare professionals. Thinking about your own What Matters to Me evolving care plan will enable you to experience true person-centred care at the right time, in the right place, and at a time of real need. Thank you. Okay, I think there has been some questions sent during my talk, and I will attempt to answer some of them. So someone has asked about the ejection fraction of 40%. Does this correlate with symptoms? And the answer is it doesn't always. People who have mild left ventricular systolic dysfunction can still have some disabling symptoms and can feel unwell. So the low ejection fraction does not always correlate with the symptoms that people describe living with on a day-to-day basis. Someone else asked, is it possible to recover from heart failure? And the answer is yes, but this depends on the reason for the heart failure developing in the first place. And I would have to say that the longer you have heart failure, then less likely that this will happen. Someone else had asked a question about Entresto, and with regards to they had developed severe symptoms associated with very low blood pressure, requiring Entresto to be stopped. And the question was, will they ever be considered to try it again? Never say never. Obviously, your clinicians will want to focus on keeping you well by improving or optimising your blood pressure and reducing your symptoms by adjusting the existing medication that you're currently taking. But each clinician will work towards optimising your evidence-based treatment at each review, and therefore recommencing Entresto will be considered if it's an appropriate intervention to do so. Another question is, how can we ensure if heart failure nurses look for advanced heart failure and frailty in younger patients? I think that's a really important question, and we have to think about the heart failure nurses as being highly skilled members of the heart failure team. And one of the key things to remember is that if you're able to develop a good relationship with your heart failure nurse, they will pick up very quickly any subtle changes that are taking place with your condition. And doing the comprehensive assessment will mean that they will focus on you as an individual rather than checking to see if it's just heart failure symptoms that are changing.